my name's Ed, and it's actually 20 years and 1 month that I've been working on Huntington's disease. So, oh, thank you. I mean, most of you have been doing it longer than me. Right. So I'm a scientist. We put question marks at the end of our talk titles, don't we? Because we want something to be true. Then we get to the actual submitting the title and we think, well, maybe it's not true, so I'll put a question mark at the end. Still, beginning of the end would be nice. And we're going to get to this, but there's a lot of stuff to cover before and after September the 24th, or whenever it was. And I think the main thing I want you to take away from my talk is the big picture here. So there are good days and bad days in all of our lives, and September the 24th was a good day, and the news is as good as it sounded at the time, but life is complicated, and so, you know, we need to appreciate as much as we can of the nuances of the situation. But things are very different from how they were last time I gave this talk. This starts to get slightly more related to what I'm actually going to talk about. I'm going to talk about Huntington's disease, but I want to share with you some big picture context. And the picture doesn't get much bigger than taking photos of deep space objects, which is my hobby. I have these now 2 telescopes. The one on the left takes pictures of larger areas of sky, and the one on the right takes very, very zoomed in pictures. And anyway, whenever it's clear in London, which is about once a month, I spend the evening doing this. So all the pictures I'll show you will be pictures I've taken from my balcony. And I want to start with this slightly unimpressive galaxy, which goes by the name C30 or NGC 7331. It's not important to remember those. But this is a picture I took of that galaxy in September of last year, so 1 year ago. And then I took another picture of it in August of this year. And to take these pictures, you have to collect light for about 12 hours, and then you put them through a computer. And I knew this was going to happen, but when I looked at the image from August, it was slightly different from the one from last year. If you just, I mean, everything looks a little bit different, but if you look up here at the galactic core, there's a new, very, very bright star, or it looks like a very bright star. You see it? Yeah. Not there, there. That's a supernova. So about 24 million years ago, a star in this galaxy exploded. And the light, the photons from that explosion, reached Bethnal Green in August of this year. And obviously I'm a scientist, so I know that that doesn't have any cosmic, well, it has cosmic significance, but it can't possibly have any significance for our day-to-day lives. But the ancients would have seen something like this and said, this is a sign of a time of great change, tumult, our expectations being challenged, and events of great significance about to take place. So we'll just bear that in mind. Let's look at a brain. We'll start to talk about Huntington's disease. So this is what it looks like inside the head of someone who has the HD mutation. This person doesn't have any signs or symptoms of HD, so they're what we would sometimes call pre-manifest. But what you can see is that the brain is shrinking. Underneath, so there's a sort of black curvy bit that's just fluid, and underneath that is the bit of the brain that we call the striatum. And that bit, you can see it shrinking over a period of 4 years, and then the video loops back to the beginning. And so that's the kind of big picture of what it looks like physically inside the brain when someone starts to approach the onset of Huntington's disease. Inside the cells, it looks like this. The little green blobs you can see are called aggregates. An aggregate just means a clump. So these are little clumps of a protein that we call mutant huntingtin, which is the cause of Huntington's disease. So you look down a microscope. These are mouse brains. They have 138 CAG repeats. You look down a microscope, you can see the enemy that we're trying to overcome. You can see it making clumps in a neuron, and you can see the neuron detaching from its neighbors and dying. And it's depressing in one way, but it's a bit like the gene itself. It's depressing, but it's also something that gives us a big advantage because it tells us what the problem is that we need to fix, what the enemy is that we need to defeat. And this is, you might recognize the middle bit of this image. If you were around in the 90s, you'll remember the Hubble Space Telescope going up and taking a picture of what was then at the time called the Pillars of Creation. And they are a star-forming region of space in what's called the Eagle Nebula. And thanks to modern telescope technology, you can see the Pillars of Creation from Bethnal Green. And what I've just told you about the gene and Huntington's disease and the Huntington protein could be thought of as the pillars of creation for all HD research, because basically that's the starting point. The gene is a recipe for the protein damages our brain cells, and that is the starting point for everything else that we now know and all of the work that we've done to try and develop treatments for HD. We like to talk, don't worry about the words on this slide, just look at the pictures basically. So on the left we have DNA, and on the right we have this protein, which is the mutant Huntington protein. We call it MHTT. It's not actually much quicker to say, but it's much quicker to write. So how do we get from DNA to protein? There's a couple of things that happen. First is that the cell makes a working copy of the gene. So the gene is DNA. The cell makes a working copy from something called mRNA. And that contains bits that we want and bits that we don't want. And then the next step that happens is the snipping out of the bits we don't want, and that's called splicing. And it's a bit like stitching a movie together. You get rid of deleted scenes, you put together the main cut of the movie. So this is the main cut of the movie, and then this is the bit that's used as a set of instructions for actually making each molecule of the protein. This goes by the grandiose name, the basic dogma of biology. So it doesn't get more pillars of creation-y than that. So this is the stuff that really is the most appealing target for developing treatments for HD. We probably can't change the DNA, although that's something we're working on. But this stuff in the middle is actually quite easy to make drugs that interact with this stuff, mRNA. Much more difficult to make drugs that interact with a really complicated protein. But that's something that people are working on. But the big focus for the past 10 years in patients and 20 years in the lab has been drugs that interact with mRNA, RNA, the message, and tell the cell to make less of the protein that we don't want around. And the first way we try to do this is probably familiar to many of you. The group of drugs are called ASOs, which stands for antisense oligonucleotide. Doesn't matter very much, we call them ASOs. And they are drugs made from DNA, but it's synthetic DNA. So you basically design a bit of DNA, give it the properties of a drug, and you inject it into the nervous system. And when that happens, it sticks to this mRNA here, and then that tells the cell to get rid of the RNA and less of the protein is made. And that's called down-regulating or switching off or silencing the Huntington protein. And as I say, that was the first approach that we ever tried in people. You probably can't see this very well, but at the top it says antisense oligonucleotide. And then the next three lines are the names that the first of these drugs that was used go by. It was initially HTTRX, then RG6042, and now most people call it Tominerson. This is the first dose of Tominerson being given by me 10 years and 2 months ago, minus 4 days. And that was the start of the era of Huntingtin lowering or gene silencing in Huntington's disease. We sort of know where this story went, but it's easy to forget that the story even of Tominerson, the first drug we tried in this group, is not yet finished. What you can see is that with bigger doses of Tominerson, you get more lowering of the amount of protein. So we measure the protein in the spinal fluid, and that's how we know whether this drug is working. And at the high dose, we discovered in 2007 that it was, and that was all published. And then we started a phase 3 study, can we get the drug license kind of study. Everyone had 2 monthly injections. Some people had placebo every time, some people had active drug every time, and some people had alternating. And as many of us know and many of us remember all too well, that trial had to be stopped overnight in 2021, in the middle of a COVID lockdown. And it was objectively very depressing and sad. But, as we know, we are not a community that gives up easily. We should be able to give up on things that are not going to work. But what we should have the main focus on is finding out whether something has a chance of working. If yes, how do we get back on the horse? If no, get rid of it, move on to the next thing. So this is how we do it in real life. We basically have to wait for the dust to settle. Even though the trial was stopped when most people had only reached 69 weeks instead of 104, loads and loads of useful results came from that trial. So top left, you can see the results from everyone. And that basically just shows that the people who had 4 monthly Tominerson did a little bit worse. The people who had 2 monthly Tominerson did significantly worse. So that's bad. That's the opposite of what we want. But if you just look at young people who happen to have smaller CAGs, so these are people who have Huntington's disease, but they're just much earlier on, or they have a more slowly progressive form of the disease. And what you can see is on the right, at the end of the study, even though it was only halfway through, the blue is below the grey. The grey is the placebo. The blue is below it, which is the same as the overall study. But the orange, which is the less frequent arm, is on the right side of the placebo, suggesting that in that group of patients, this amount of drug might have been pushing things in the right direction. The other obvious thing that we saw was this spike in the level of a protein in the spinal fluid called NFL. NFL is released from dying or damaged neurons. So if it goes up, that's bad. If it goes down, it means we've rescued neurons or slowed the rate of damage to those neurons. And it never really got below 0, but the fact that it went up and the biggest spike was in the people who had the most frequent treatment is a sign that something was happening early on when people first started getting this drug that their nervous system wasn't happy with. And I won't go into detail of this, but this is a graph of lots of different biomarkers, different measurements made in the spinal fluid after people received treatment. So the red one is how much the Huntington protein was reduced, so that's a good thing. But the pink one is how much the NFL went up, and that's a bad thing. But if you look at the people who had the lowest amount of Tominerson, so these are the people who didn't get any, and these are people who just got a little bit of Tominerson, the Huntington still goes down quite nicely, and actually you don't get much of an NFL spike, and other stuff starts to move in a favourable direction. And so from all of this and other evidence I don't have time to go into, I think it was generally concluded that this one drug, Tominerson, deserved another chance because the doses that were selected and the dose regime was too intensive. And basically the brains of people with HD were too sensitive to the side effects of the drug. The drug, and all drugs like it, these ASO drugs, if they're given in too big doses, they can cause inflammation in the nervous system. And it looks like that's what happened. And so the drug never really got a chance to show that it can work because all of that side effect inflammation stuff happened at the beginning. And so people were kind of on the back foot. And if there was ever going to be benefit, it would have been impossible to show it within the setting of that trial. So I don't necessarily need all of this. You know what, I don't think this slide's very helpful. There we go. So that was generation HD1. And Roche, which is running this program, could have said, that's a negative trial, it's the end of the line, we're putting Tominerson in the bin or we're going to sell it to someone else. Instead, they said, because we've done this post-hoc analysis, this analysis after the end of the trial, we believe that there is actually potential for this drug at the right doses in the right people to produce benefit. And that's where this second study, generation HD2, comes from. And it's a smaller study, basically designed to try to find the right dose of Tominerson and the right group of patients to give it to. So this trial is actually about halfway through now. We don't hear much about Tominerson these days because Roche is a bit more low-key about it. But people have been regularly dosed, and this trial is due to end towards the end of 2026. And the reason I mention it now, not just to sort of dig up skeletons along with the Halloween theme, but because in April of this year, there was an update from this trial that was sort of low-key, very good news. It's not obvious because the way it's expressed, it's no concerns raised regarding participant safety, blah, blah, blah. Additionally, the 100 milligram dose was found to be more likely than the 60 milligram dose to result in clinical benefit. Therefore, for the remainder of the study, only the 100 milligram dose will be tested against the placebo, and the 60 milligram dose will be discontinued. Now, behind the scenes, this was what's called a blinded analysis. So I'm part of the steering committee, the group of experts who helps the company figure out how to run the trial, but I do not know what the results are. Even the people at Roche who work directly on the study don't know what the results of this analysis were. It's what's called an interim analysis. So it's done when the study's about halfway through, and it's completely blinded. So only the safety committee, which is another group of neurologists and psychiatrists, knows what the results actually show so far. Everyone else remains blinded, and that's important. But as a result, the recommendation of the safety committee was that of the 2 doses, 60 milligrams and 100 milligrams, there was essentially no, I don't want to say more than we can actually say here. Essentially, the 100 milligram dose was looked at in terms of whether it had a real prospect of showing a positive result. And the same was done for the 60 milligram dose. And the result of that analysis, whatever was done behind the scenes, the result was stop the 60 milligram dose and put everyone on the 100 milligram dose. So I think what this can be described as is a futility analysis, which is basically something that you do halfway through a trial with the hope that you can show that either there's no point carrying on, or there is a decent chance that one of these doses will be successful. And what this tells us, the fact that they said no to the 60 milligram dose, yes to the 100 milligram dose, I think behind the scenes means they've already started to see a potential signal that is expected to show benefit. I may be wrong about that, but if it was all negative at this point, they would have pulled the plug. They've spent millions, hundreds of millions, in fact, probably, on this compound. If it's not going to work, they will not want to keep studying it. But the fact that they've committed themselves to another 18 months of funding and everyone's going to get the higher dose of the drug, you haven't heard the last of Tominerson, let's just say that. So that's just one of many different approaches. 2 companies, Wave Life Sciences and Vico, also have active trials of ASO drugs, these drugs that are injected into the spine made of DNA. These both of these clinical trial programs are active. Wave Life Sciences has run into a potential issue, but as we've discovered with Tominerson, identifying an issue or a challenge can be useful if you use that information in the right way. So these patients who were given this particular ASO made by Wave Life Sciences experienced a spike in NFL, which starts to sound a bit familiar. If you remember, the Tominerson ASO did exactly the same. And so after 3 doses of this ASO, essentially all of the patients start to get this spike. And it's probably actually a bit of a bigger spike. I put the yellow and orange lines on that represent how high the NFL went in the Tominerson trial. And you can see it's probably higher in the Wave program. So Wave has at the doses that they've tested, have identified that they are probably going to start to cause similar problems to Tominerson. And so it remains to be seen what happens next. Wave has announced that they're going to do another trial, and my hope is that they will start with lower doses further apart, but that remains to be seen. But that trial is probably going to be announced publicly fairly soon. And the Vico Therapeutics is an interesting one because it's an ASO, but instead of targeting some random bit of the Huntington gene, it's actually directly targeting the CAG repeat. Again, it's not rewriting the DNA, but what that means is that there should be some potential for the Vico drug to have a more powerful effect in people who have bigger CAG repeats in their DNA, which could actually turn out to be a very good thing, because we know that people who have more CAG repeats will tend to have a more severe form of Huntington's disease that comes on earlier, progresses more rapidly. So a drug that has the potential to do more good if people need it more has an obvious appeal. There is a downside to this approach, which is that CAG isn't just in one gene, the Huntington gene, it's in a load of other genes as well. So it remains to be seen whether that is overall good or bad or somewhere in the middle. What we know is that a few people have been treated with this Vico compound, and it's reducing Huntington protein, which is what we want it to do, but they've had some cases of inflammation, which sounds familiar at this point. So this was actually inflammation in the nerve roots, which sit next to the spinal cord. in the fluid that the drug is injected into. So it gets a very high dose of drug. And so there was some alarm when these cases were reported, but I think that Vico is doing the right thing. They basically decided, instead of pushing ahead with a new trial, they're adding a new arm to the current trial that would be given lower doses of ASO further apart to see if we can get into that sweet spot where we get enough lowering of Huntington without causing inflammation. So we're learning, you know, as a field, maybe not as quickly as we would like to, but we are learning. You know, that photo I showed you was the first time any ASO drug had been injected into anyone with Huntington's disease. And so 10 years sounds like a long time, but when it comes to a completely new class of molecules that has to be given by injection directly into the nervous system, 10 years is actually not a very long time to start mapping out the, you know, potential advantages and pitfalls and the balance that we need to strike. But we have come a long way. So on the right is my photo of the Horsehead Nebula, which is in the constellation of Orion. And you know Orion has 3 stars in its belt. The middle star is called Alnylam, or Alnylam, strictly speaking. I don't know what it means, but that's the name of the middle star. But the middle star of Orion's belt is quite boring. So the star I'm showing you here is the left-hand star, which is called Alnitak. And that's the one that has the Horsehead Nebula, which is my brother's favourite nebula. Anyway, it probably doesn't mean anything that there's a company testing a drug for Huntington's disease that has a celestial name, but the ancients would have had something to say about it. Their drug is called ALN-HTT02. It's a bit like the Tominerson in that it has to be given by injection into the spine. By the way, put your hand up if you are in a drug trial at the moment, if you're in hands up if you're taking Tominerson or Alnylam. Anyone in the room in part of a drug trial? I mean, it makes the important point that the number of people who can actually get into these trials is very small. And you guys are a very active part of the HD community. But one of the reasons it takes such a long time to test these drugs is because each center will only have a very small number of slots. In any event, ALN-HTT02 is another injected drug, and it basically works in a very, very similar way to Tominerson, but it's slightly to the right of the diagram that I showed. But it's basically doing the same thing. But because it's 10 years have gone by, the Alnylam drug is probably going to be a bit more potent, so it probably only needs to be given every 6 months or even once a year, which is a distinct improvement. And it may actually have the ability, based on preclinical data, so data from animals, plus data from similar drugs that Alnylam has developed for other diseases, it may have a better potential to treat the whole brain rather than being just very focused around the bit of the brain that's next to the spinal fluid. That trial's underway. So not only do we have ASO, 3 ASO trials underway, we also have this new Alnylam trial, which is testing something potentially even more exciting. This is the Whirlpool galaxy. And it's actually 2 galaxies, a big galaxy that is eating a smaller galaxy. And it sounds gruesome, but this is kind of how science works. A big galaxy comes along and encounters a smaller galaxy, and instead of just ignoring it or obliterating it, the 2 basically merge, and then what you get is an even bigger galaxy that contains the wonders of both galaxies. And it's slow, but this is the inevitable way that the universe works. So what this represents, and for the purpose of my talk, is the idea that we may have a focus on one particular thing, and then something else will come along, take us by surprise. But if we play our cards right, we can use this new scientific breakthrough to our advantage, and we can absorb it into our galaxy. Yeah, that okay? That works, kind of. I'm far be it from me to say that I'm only showing these astro photos to show off. This is all science. So let's talk about this drug. Top left, you can see the word Votoplam, and that is the name of the drug. Things get complicated because of capitalism. So the drug was invented by a company called PTC Therapeutics, and they called it PTC 518, and then they called it Votoplam, and the trial was called Pivot HD. And then just before Christmas last year, Novartis took an interest, Swiss drug giant Novartis, purchased the drug for between $1.8 and $3 billion, depending on how it goes. I know, right? And so now it's still called Votoplam, but it belongs to Novartis. So if people say the PTC drug or the Novartis drug, they mean the same thing. We just got... So what is Votoplam? This is important. So Votoplam is the first Huntington-lowering pill that we have tested in a meaningful way. So you'll remember that Tominerson and the Alnylam drug and the Vico drug and the Wave drug all have to be injected into the spine more than once a year. And that, if we have to do that, that's fine, but it would have to be done repeatedly throughout the person's life. And it's far from convenient for everyone, and it's pretty expensive as well. So a pill would be better, easier, and more convenient, probably cheaper, certainly much easier to get to everywhere in the world that we need treatments, including the much less developed parts of the world. Places like Venezuela, where there isn't really food on the supermarket shelves, are not going to have an easy time with spinal injections or anything of that caliber. So it's really important that we explore all options, including these pills. And the way the pills work, it's not important to go into it in great detail. They're basically doing something very similar to what Tominerson does, in that what they're doing is preventing the formation of the protein. They happen to be doing it by interfering with the process of splicing, so the way that the RNA is kind of edited together to produce the final cut. But the bottom line is, these are a pill that gets into the brain. The pill doesn't get into the brain. The pill dissolves, and then the molecules go into the brain. And that reduces the production of the Huntington protein. And what we can see bottom left is the results of about 50 people having 2 years of treatment. The grey bar on the left is actually, this is a smaller group of patients. I'm sorry, I misspoke there. So this is 2 years of treatment. They had 12 months of blinded placebo-controlled treatment and then 12 months of open-label treatment. And so on the left is a group of control patients, not from the trial itself, because all of the trial patients are now in one of the treatment groups, but rather from Enroll-HD. So hands up if you've been involved in Enroll-HD. So without knowing it, you probably took part in this trial. Congratulations. 33,000 people, or thereabouts, have taken part in Enroll-HD. And when a company or a drug developer needs to know how their patients are faring compared to how untreated patients might do, the best way is with a placebo arm. So a group of patients who receive a dummy pill, and then we get a direct comparison. But if that's not possible, for instance, if all the patients who are on placebo are now on active treatment, we have to look elsewhere. We have to look at a group of patients not in a drug trial, but who have generated reliable data. And this is called an external control cohort or a natural history control cohort. And it's a standard way accepted by regulators for looking at the biological effects of an intervention. So in the blue is low dose, Votoplam. Purple is high-dose Votoplam. Grey is people who didn't receive any treatment. And what you can see is that there's about a 20% reduction in the amount of change from baseline to year 2 in the blue one, and a slightly lesser reduction in the purple one. But overall, this is a result that suggests that the progression of Huntington's disease in these people has been slowed compared to where they might otherwise end up. Now, it doesn't, because it's using an external control from Enroll-HD, this doesn't take into account the placebo effect, so we can expect the real effect, if anything, to be slightly smaller than this, but it's not zero, and it's bigger, the effect is bigger in the high dose than the low dose. And this is patients in what we now call stage 2 Huntington's disease, which is people who may have some signs or symptoms of HD, but it hasn't started to cause functional impairment yet. Crucially, you'll remember top right what happened in the Tominerson program. There was this NFL spike, and that turned out to be a sign that things were about to go wrong. In the Votoplam trial, no NFL spike. Okay, so this drug has already cleared the potential pitfall of causing side effects early on that would be detected by an NFL spike. And Novartis now is in the advanced stages of planning its own phase 3 trial to take this drug and test it over a longer period in a very large group of people, a bit like the Generation HD1 trial in terms of its size and scope, but with the hope that they can show for sure that this drug is slowing the progression of HD. So that's encouraging. That's a pill. That result, even though it's not from the end of a program and there's more work to be done, we can glean certain new facts from that trial that we weren't able to state with confidence before. The first thing is that a pill that lowers Huntington, right? I don't have the graph, but this drug is reducing Huntington by between 25 and 40%, depending on the dose, which should be enough to make a difference. And it is not causing a big spike in NFL. There were concerns from this group of drugs called splice modulators, these Huntington-lowering pills. There were concerns that could cause off-target effects that would cause damage. And that hasn't been shown with Votoplam, which is great. The other thing is that it's a slightly more subtle point, but it's a really important one. Each of us has 2 Huntington genes, one from mum, one from dad. And the one that has the expansion, that's bigger than we would like it to be, that's the one that causes Huntington's disease by telling the cell to produce the mutant Huntington protein. But the other copy, in almost every case, is not harmful. It has a normal-sized CAG, which produces a healthy version of the protein. And there have been big, understandable concerns that if we lower both forms of that protein, then you could do some good by lowering the mutant, but some bad things by lowering the sort of healthy form of the protein. Scientists call it the wild-type protein. It's not named after me, but it's nice to imagine. So in an ideal world, we would have a treatment that lowers mutant but not wild-type. But that's really, really difficult to do. And so almost all the drugs that we've been testing in people are going to lower both forms of the protein equally. So a big question if something goes wrong, like when we see an NFL spike, a lot of people, when this result came through with Tominerson, started saying, that's because you're lowering both forms of the protein, and we told you that was a bad idea, and that will always be a bad idea, and you should never do it again. People actually said that. The fact is that this result from PTC shows that you can lower both copies of the protein, and it doesn't necessarily produce an NFL spike, and is therefore, over the periods that we've tested it, safe. And that's really encouraging, because if we have the green light to go ahead with treatments that only lower the mutant, as well as treatments that do both, then we can test more drugs, more options, more shots on goal, more ways up the mountain. Now, there's another newcomer in town, Skyhawk Therapeutics. Well, what's this got to do with Australia? And I thought you were supposed to be showing us photos of the cosmos. Well, if you look, it's very, very, very difficult to see, but if you look at, you can see a flag in the middle of the Golden Gate Bridge, and this is a photo I took, so it's permissible. Up and to the right, there's a 1 star. Can anyone see that? Maybe just the people in the... That's actually a planet, it's Venus, which has been called the morning star and the evening star. And fans of Lord of the Rings will know this is the light of Earendil, one of the Silmarils in the sky. One of the Silmarils, in the sky. Anyway, so it's technically an astrophoto, even though it's clearly of Sydney Harbour Bridge. What's any of this got to do with Huntington's? Well, Skyhawk is an American company, but has taken the innovative and I think clever decision to carry out the early phases of their clinical trial program of their Huntington-lowering pill exclusively in Australia and New Zealand. So they're below the equator and a little bit below the radar. But we have started, and their drug's called Sky 0515 because the 15th of May is Huntington's Disease Awareness Day in the US. So that's quite cute. So their drug is exactly the same as Votoplam, which we just heard about, but it appears to be substantially more powerful. So for the equivalent, the same number of milligrams, the same number of molecules in effect, you get a bigger reduction in Huntington. So you can see here, day 84, which is probably 3 months, people with HD taking the Skyhawk drug every day were at 62%, but you can see the line is still going down. So it could end up really, really low. Like this could be a drug that could reduce Huntington by 70, 80, 90%. We don't have to do that if we don't need to, and so they're testing lower doses as well. But this is now the second oral drug that lowers Huntington and does so without causing significant increases in NFL. So votoplam has been tested for longer. So far, looks like it may be producing clinical changes in the direction we want and is not increasing NFL. Sky515, similar mechanism of action, more powerful, and so far not causing problems with NFL spikes, but is earlier on in its development program. This is one to watch, I would say, and another trial will be coming soon. This is the Wizard Nebula. I was in Italy a couple of months ago, and I had 2 nights in an 11th century watchtower where I took this picture of the Wizard Nebula. The point of this is, it brings me back to Lord of the Rings, in which Gandalf, of course, says, "A wizard is never late, dear Frodo. He arrives precisely when he means to." And this, of course, brings us to uniQure. Okay, I've got 9 minutes. So, uniQure is a gene therapy company founded in Amsterdam, and most of its activity takes place in Boston. The drug that they have developed for Huntington's disease is the first gene therapy for HD, and it goes by the name AMT-130. And then it has a name that begins with II, and no one ever says it because it's too long. So what does it mean if something's a gene therapy? What it means is it is a virus, a harmless virus called AAV5, which doesn't cause a disease in humans. But you can take that virus and reprogram it with whatever DNA you like. If you program it with the right DNA, it becomes a drug. And if you inject that drug into the deep structures of the brain, the striatum, here, and shown here on the MRI scan, then the virus attaches to the neurons and other cells, injects its DNA into those cells, and then it stays there forever, till the cell dies, as far as we can tell. That little bit of extra DNA then becomes a recipe that turns the cell into a factory to make a drug that lowers the Huntington protein. So it's a little bit like the Alnylam drug, but instead of the drug having to be injected, you do a one-off brain surgical operation and reprogram the brain to make a drug every day, 24/7, for the rest of the person's life. So it's the definition of high risk, high reward. There's a lot of activity up front, but it only needs to be done once. And this operation takes between 12 and 20 hours, as far as we can tell. And it's done in MRI theatre, so there are not many places in the world that can do this operation. But if the drug gets licensed, then there'll probably be a lot more on their way. So where are we up to? The first patient was treated 5 years ago in June of 2020. That was in the US. And in the US, there was a placebo arm where patients had an anesthetic, incisions in the scalp, and then they were woken up, and that was it. The European regulator, the EMA, said, we're not going to do that. That's cruel, and it's not going to help us. So no sham surgery in Europe, thank you very much. So we ended up with this slightly hybrid design. First European patient was treated in February 2022. In the UK, there are 2 clinical sites. One is in Cardiff, where all the surgery was done by my friend and colleague Liam Gray, and the site PI is Anne Rosser. And UCL in London, site PI Ed Wild. And we each have 2 patients in the trial. So it's a small trial, but it's a slow burning process. This time last year, or there hereabouts, there was a regulatory update, and then we were all eagerly awaiting the 36-month results. And this, I think, is the graph that changes everything for everyone. Because, once again, let's get ourselves acquainted. The grey bar is an external control, which we've already heard about from the PTC trial. So all the patients and people who took part in Enroll, 568 of them were chosen by an automated system called propensity score matching. And those people are a very close match for the small number of people who were in the trial and received the gene therapy. So on the right is how much patients in Enroll, who look the same as the gene therapy trial patients, but obviously didn't get gene therapy, deteriorated over the space of 3 years. And on this score, which takes into account lots of different aspects of HD, it was about a 1.5 point drop. So it's about half a point per year. Patients who were treated with a high dose of gene therapy deteriorated by 0.3 over 3 years, so about 0.12 per year instead of 0.5. It is a 75% slowing of the progression of Huntington's disease in those patients. Yes, I do agree. A year ago, the result that we were shown was an 80% slowing, but it was against a different group of patients. And this is actually a tougher bar, but has shown essentially the same amount of slowing. Now, what's crucial to realize here is that 75% of slowing sounds great and is great, but it is not a halt. The disease has not been halted overall in these patients. They are still progressing, but what used to take 1 year is now taking 4 years on average. And that's a huge difference. You know, we don't want to be sustaining people in a quality of life that is not acceptable to them. But if you have an acceptable quality of life, I think it's much better to be in that state for 4 years instead of 1, or for 20 years instead of 5. And in theory, if we give this gene therapy to people before symptoms begin or before they become severe, we should be keeping people in a completely normal quality of life for much, much longer, many years longer, if the drug behaves as well in the real world as it appears to in the context of this trial. This is what it looks like over time, okay? So this is the same result, but divided into 1 year at a time. And you can just see how inexorably the patients who weren't in the trial progressed. The people in the trial, they have progressed a little, but not much. And the lines are getting further apart. So, you know, this is what I'm talking about. These people will inevitably continue to deteriorate at roughly this rate. And the treated patients, remember, their brain is still producing the drug molecule. So they should continue to either progress very, very slowly, or who knows. Things could change in the future. But this looks very good so far. Well, what about that's one sort of aggregate score that's a bit abstract. What about the specific things that were measured? So the tests on the left, SDMT and Stroop word reading, you might know these. This one is matching numbers to symbols. This one is reading out the names of colours. So these are cognitive tests, thinking tests. And as you can see from the grey bar, over time, they get worse. But in the orange treated patients, there was a significant reduction by about 88% in the decline in the symbol digit test. And people treated with the gene therapy were actually better at the end doing the other cognitive tests than they were at the beginning. They actually improved, and the control patients didn't. The one on the right is motor score. They did get worse, but again, it was by less. This was a less impressive result than the others, but it's still heading in the right direction. And one thing I haven't put in here is that the test of function that we call the total functional capacity was also stabilized by about 60%. And what you can see is that actually between years 2 and 3, if anything, it's turning towards improvement. But what happens next is anybody's guess. But it's a bloody good start. So that's all great, but what if this is all placebo effect? Or what if these are just a group of people who are going to be fine anyway? This is where NFL, a biomarker, comes into it. So NFL has been a big focus of my research, and I'm really pleased that my research has ended up being informative in the way that it has about these clinical trials. So in my HDCSF study, we looked at these patients over a couple of years, and what you can see in the placebo patients are in grey. I'm sorry, these are healthy controls in grey, patients in blue. You can see in almost every case, actually it's about 3/4, over 2 years, 3/4 of patients experience an increase in NFL. And on average, it goes up by about 10% per year in this group of people. In the gene therapy trial, in the low dose, they ended up about 5% lower than the start. And in the high dose, it was about 8% lower than at the start of the trial. So the NFL is lower at the end than it was at the beginning. And there is only one plausible explanation for that. There are other possible explanations, but they are so unlikely that I do not think that they are plausible. I do think that the only plausible explanation here is that the rate of death of neurons has been slowed by the gene therapy. This slide also points out that this is a result in only 11 people, okay? So the first thing to note is this is a very small group of people, but it's also a group of people that's been studied for a very long time. It's really rare for us to have 3-year data from any clinical trial. So there is more to what we call a signal emerging from data than the sheer numbers. A smaller number of people, if followed for a long enough period, can produce a result that is equally definitive. This is not a definitive result, but it's an incredibly good result that suggests that this is the first disease-slowing treatment for Huntington's disease. There are many challenges ahead, and it's really important that we get our heads around them, because there may be things that we need to do as a community to keep things moving in the direction we would like them to. So down the left are the world's main 3 drug regulators. In the US, the Food and Drug Administration, FDA. In the European Union, the EMA, European Medicines Agency. The UK, post-Brexit, has its own medicines regulator called the MHRA, Medicine and Healthcare Products Regulatory Agency. They are the first hurdle that this drug needs to overcome if we're going to start giving it to the people who need it. So the sponsor, uniQure, is in discussion with the FDA now about asking for accelerated approval. What's accelerated approval? Well, I'll tell you. On the top, we have the standard approval process. You do a small phase 1 study, a medium-sized phase 2 study, a very long phase 3 trial, which can last up to 5 years start to finish. Then the FDA looks at the data, and then if it looks good, they approve it. That's a very long process. We can do that if we need to. A faster process, you get to the end of an earlier study. This was a kind of a phase 1/2 study. Not important what the difference is, but this is where we are. FDA can then review the data, and if it looks sufficiently promising, they can approve the drug there and then, on the condition that there's some kind of study that is started that confirms the data in the real world. And that can be either a phase 3 trial, or it can just be collecting data from real-life people who are not in a trial. So fast-track accelerated approval is an option with the FDA. It's not at all clear whether the EMA has a viable pathway for us for accelerated or conditional approval. Probably not. For mainland Europe, it's likely that another long trial will be needed, studying more people. Just because in order to get that kind of accelerated approval by the EMA, you have to state in advance that is the intention of the trial, and you have to agree the way that will be done in advance. And that wasn't done because no one really expected this trial to generate data as good as it has. MHRA is new. They haven't made many decisions because everything was done by the EMA until quite recently. But what they have styled themselves are, in their kind of new post-Brexit form, is an agile regulator, which has the potential to look at special cases of, for instance, rare diseases, or a drug that's shown a powerful effect, or a drug that would be difficult to test in a longer trial. And they claim, at least, to be open to and interested in the possibility of being the regulator that makes decisions about rapid access and how that will work in the real world. That's not guaranteed, but it is something that is at least a potential for people living in the UK. There will inevitably be setbacks here, okay? I'm amazed that we've reached this point and we've seen data as good as we've seen. Because honestly, when I first saw those data, it surpassed my wildest possible expectations. And I've been going around telling everyone, don't get your hopes up. Everything that looks good tends to look less good the next time you look at it. That's called regression to the mean, and it's a real sort of statistical phenomenon. So when things were basically as good at the 3-year time point as they had been at the 2-year time point, I was really thrilled. But there are lots of ways in which this could go wrong. Any regulator that wants to, for any reason they want to, can say no to this drug. They can say we don't do accelerated approval. They can say we've changed our minds. They can say we're not convinced by the data. They're all at liberty to say that. I hope they won't, but they can if they want to. But if that happens, we can deal with it. We are a community that overcomes adversity. What we can't overcome, we live with, and we focus on ways to make life better. And that's what we need to do here. So have a general awareness of what's happening, a lot of waiting, and listen out for things that the community may need to do in order to make things happen in the way we want. This is the mountain called K2, and the point here is that there are many ways to reach the summit of a mountain, and we are exploring many ways to treat Huntington's disease. If we only think about the Huntington lowering drugs, there's half a dozen in clinical trials now. There's at least another dozen waiting behind the wings, behind the scenes, to come into trials. And a pause or a backward step on one of these pathways not only doesn't immediately destroy our hopes of reaching the summit through some other means, but it also generates useful information that people on the other paths can use to make their path to the top as smooth as possible. So what can we do? Right now, one of the questions I'm frequently asked nowadays is, should I get tested so I can receive the gene therapy? I think the answer to that is no, because I don't know whether the gene therapy will ever be available for prescribing. If it is, it's not going to be soon. I don't think anyone in Europe will be treated with this drug before the end of 2026. If we're lucky, it might start happening in 2027, but it might never happen, or it could happen with significant delays. Or you could hear that the drug has been licensed, but NICE has refused to pay for it because it's too expensive. And there are various ways in which we can help to change that decision if that's what we want to do. But for now, I would say your reasons for testing or not are your own. We always knew that science would move us closer to an effective treatment. I want there to be a dozen effective treatments. And that day gets closer by one day, every day. And with this news, it got substantially closer. But we're not there yet. And I can't tell you for sure that we'll ever get there, except that we'll all keep trying. So I wouldn't recommend that anyone gets tested as a result of this news, but I would encourage you to have a discussion with a genetic counsellor about what it might mean for you. And if you feel like it's made a difference to your likelihood of getting tested, just have that conversation and allow the counsellor to sort of go through that conversation with you. And, are the assumptions reasonable? Are you basing it on reasonable expectations? But if you've had a positive gene test and you're not an Enroll-HD, I strongly urge you to get into a clinic that runs Enroll-HD, take part in the Enroll-HD study. It's not mandatory, but it is extremely useful because the sites that run Enroll-HD use the data that are generated by Enroll-HD assessments to figure out who may be suitable for any clinical trial that comes along. If you're not an Enroll-HD, it's another potential barrier to getting into treatment or trials in the future. It won't be like that eventually, because if these drugs become available on the NHS, we'll be prescribing them, and then we'll just have to figure out how to assess people in some other way. But for now, Enroll-HD is how we figure out who is where in their disease. And so when something gets licensed, that's where we'll look. So I'm sorry, I only arrived during lunch, so I don't know if the parliamentary event on the 19th has been mentioned. Probably it has. It's on the HDA website if it hasn't. This was not set up to discuss the gene therapy at all, but the timing is actually really good because it's a chance to speak to the people who write the laws in our country and tell them what it is that we want them to do. So if you haven't already, whether you can make it yourself or not, please invite your MP to attend this meeting. Because the more people in that room, the more people that we, collectively, those of us who will be there, can have spending time talking to the lawmakers about what it is that we would like to happen. If you don't know who your MP is, you can go to theyworkforyou.com. And I would please don't say to your MP, get this drug licensed or push this drug through or anything like that, because even if they wanted to, they can't do it. I would suggest that you express enthusiasm about the results and enthusiasm for the regulator making a rapid and sensible decision or something of that kind. The video will be online of this talk if you're stuck for a turn of phrase. So that, I think, is where we're up to with uniQure. Incredibly good news, but lots that could go wrong, and something will go wrong, and we've been there before. But this result, I don't think, will be taken away from us. I do not think that, I think this will remain the first drug that has showed convincing evidence of rescuing neurons and slowing the progression of Huntington's disease. But, like I said at the beginning, this is not a treatment that is going to treat everyone who needs it. If we really, really, really push ourselves, we might be able to do one of these a week in the UK, which is 52 patients a year. It's not enough. It's not nearly enough. It's amazing for the people who can get it. But the reality is, in the UK, and even more so beyond the UK, we need treatments that are much, much easier to administer. No one's free until everybody's free. And this brings me to the ghost of Cassiopeia. Cassiopeia is a W-shaped constellation in the night sky. The middle star is called Gamma Cassiopeiae, and this nebula is just a bunch of interstellar matter that has fallen into the gravitational pull of the star and is being drawn inexorably to it, which reminds me of how we as a community are drawn inexorably towards a better future. We may not be happy about where we are now, but we have a direction of travel that is going to get us to somewhere better, and it is inevitable. I don't know when, but it's as certain as the law of gravity. This community will continue to work towards its aim until we get there. I will very, very quickly talk about some other things that are happening. Skyhawk Therapeutics is the second gene therapy for Huntington's disease. It's run by Roche. They bought Skyhawk Therapeutics. The first patient was treated in June 2025, and it's lowering Huntington. And then there's this idea of somatic instability. I won't go into it in great detail, but suffice it to say, your blood test doesn't change. The number of CAGs in your blood doesn't change overall as you age. But in brain cells that are important, it does grow. And the growth of the CAG, which seems to happen by accident, is one of the things that drives the progression of HD. And we did this big study of 9,000 people. When I say we, I mean the community. 9,000 people, and discovered that a lot of the genes, other than Huntington, that are affecting the progression of HD are to do with DNA repair. So there's this whole machinery that repairs DNA. And what's probably happening is that there's a DNA gets broken all the time, every day, in every cell. And then so we have this machinery for repairing it. But occasionally when the repair machinery gets it wrong, it's adding an extra CAG. And if that happens enough times, it becomes it becomes something that accelerates the progression of HD. So what we want to do is make a pill that makes the DNA repair machinery behave properly. And all of these companies are working on either pills or injections or gene therapies that do that. And it's the two approaches that I've talked about, Huntington lowering and reducing the tendency of CAG repeats to expand, should work really well together as a sort of package for protecting someone's brain throughout the whole life. And these are all expected to come into the clinic soon. You'll probably recognize these two people. One of them is Winston Churchill. The other is Professor Sarah Tabrizi, my friend and mentor. And this was a slide that I made for her as a special surprise when she was giving a talk in 2011 to the World Congress in Melbourne. She wanted a slide to accompany her belief, echoing Churchill. And this was 15 years ago, so this was before any of the trials I've talked about. But after we'd made progress in figuring out how HD affects the brain, basically. She said, quoting Churchill, "This is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning." And I think that was a reasonable thing for her to say in 2011. I think that we have, with this news in September, reached the beginning of the end for Huntington's disease. And I'm so optimistic that I'm replacing the question mark with a full stop. Thank you.